Welcome back to Beyond the Heart. I'm your host, Dr. Nieca Goldberg. You're listening to Beyond the Heart on Sirius XM 110. And in this segment, we're going to be speaking with Dr. Daniel Laroche about glaucoma. Dr. Laroche is Director of Glaucoma Services and President of Advanced Eye Care of New York. He's affiliated with the New York Eye and Ear Infirmary and Assistant Professor of Ophthalmology at Mount Sinai School of Medicine here in New York City. Welcome to the show, Dr. Laroche.
Thank you so much for having me, Dr. Goldberg.
It's great to have you here. So for our listeners who may not be familiar, can you explain what glaucoma is?
Yes. Glaucoma is a condition that affects the eye, mostly in the elderly. It affects the optic nerve, which is the nerve that connects the eye to the brain. And usually it's associated with elevated eye pressure, but in rarer cases it can be associated with a lower normal pressure and decreased blood flow. And the main cause of this glaucoma is elevated eye pressure usually. And this elevated eye pressure damages the optic nerve that leads to loss of peripheral vision slowly but surely that can lead to irreversible blindness. And so it's very important to get screened and get checked for glaucoma.
So what are risk factors for glaucoma?
Risk factors are age, family history, myopia, high hyperopia, narrow angles. Women have a slightly higher prevalence than men as well. Those are the main risk factors for glaucoma.
Now, I'm sure you've been finding this. People have been very neglecting their overall health during the pandemic because of their concerns about going for preventive visits. But how often do you recommend for a person to see an ophthalmologist or start screening for glaucoma?
People over the age of 40 should go to the ophthalmologist once a year to get checked, one, to make sure that their vision is 20/20, to get checked to make sure they have the accurate prescription for glasses.
Sure.
They get their eye pressure checked. The normal eye pressure is 15 in the eye in most people.
Oh.
But when your pressure gets up to about 18 or higher, that's when you start to look very carefully for glaucoma, and glaucoma can develop. And the thing is, you don't feel that higher eye pressure. It's a silent thief of sight. And then when you go to the eye doctor, they'll check your lens to make sure you don't have any cataracts. They'll take a look at the optic nerve to make sure there's no optic nerve damage or excavation. They'll take a look at your retina to make sure there's no retinopathy from diabetes or hypertension and or macular degeneration, which usually starts in that more elderly population in the 60s and 70s.
So how does to get checked, but how does macular degeneration, how is that different from glaucoma? How do you differentiate those?
Well, with macular degeneration, the eye pressure is usually normal in the eye, and it affects the part of the retina, which is a lining inside the eye that transmits the images to your brain. And then there's a certain part of the retina called the macula or the fovea, which is what gives you that 20/20 vision. So when you're looking at something, you're using that part of the retina, the fovea, that gives you that 20/20 vision. And that degenerates. The photoreceptors in that part of the retina degenerate, usually due to excessive sunlight exposure, age, genetics, and so that can lead to loss of central vision, not peripheral vision, but central vision, and interfere with your ability to read. So it's important to get checked for that as well.
I'm going to open up our phone so our listeners can ask questions because I want to make sure everyone's taking care of their eyes. And they can give us a call at 877-NYU-DOCS. It's 877-698-3627. Of course, if you're shy, there's the email option, docs@SiriusXM.com. I'm on the phone with Dr. Daniel Laroche, who's an ophthalmologist here in New York City, and he specializes in glaucoma and eye diseases, and we're opening up the phone so he can take your calls. So Dr. Laroche, is glaucoma the leading cause of blindness in African Americans and people from Caribbean? Do we know why?
Yes, it is the leading cause of blindness. The prevalence of glaucoma in blacks and people from the Caribbean and African descent is about 4 to 8 times higher than the rest of the population. And the rate of blindness is about 8 to 15 times higher. There's a couple of reasons for that. One is lack of access to eye care. For decades, unfortunately, in America, we inherited a system that was racially segregated and discriminated. So for many, many years, although whites could go to medical school, blacks could not go to medical school or become eye surgeons. In America, we have 40 million African Americans, but only about 400 eye specialists that are African American descent. And there are 26,000 ophthalmologists of other races, racial descent throughout the United States. And unfortunately, because we have a lot of residential segregation, there's a shortage of black ophthalmologists in the community. So a lot of blacks have a lack of access to eye care. So access to eye care is a big problem. That's one. The same thing happens in the Caribbean. In Haiti, for example, you have a population of 9 million, but only 50 ophthalmologists. In Ghana, you have a population of 30 million, but only about 90 ophthalmologists. So there's huge decreased access to eye care due to the history of slavery, colonialism, and segregation. So we have to. Are you working
with your organizations to find a strategy to improve things?
Well, yes. The American Academy of Ophthalmology is taking efforts. The National Medical Association has been working since 1895 to help increase diversity in ophthalmology. And this doesn't just apply to ophthalmology, but also all other medical specialties.
I know.
There's so much healthcare disparities with the COVID-19 pandemic as well. So we have to increase the training of more black physicians as well, diversify the workforce. And then the other reason is I think we've been treating glaucoma wrongly over the last several years.
Okay, so I want to hear about that.
Yeah, we've been using medications and laser as first-line therapy for glaucoma. And we know that over time, people still progress and get worse with medications and laser treatment. Now there are newer, safer techniques with earlier cataract surgery and trabecular bypass, which can dramatically lower the pressure, eliminate the cause of the glaucoma, which usually is the large lens in the eye, and get people off of medications and really help preserve their vision as well. The main cause of glaucoma in my practice that I see is the enlarging lens in the eye. With age, the lens enlarges by about 20 to 30%. And that contributes to the elevation of eye pressure by narrowing of the drainage angle and by the lens rubbing up against the posterior pigment epithelium of the iris, releasing pigment that blocks the drain, the trabecular meshwork in the eye. And so when we do earlier cataract surgery, take that lens out, okay, and open up a drain with a trabecular bypass, which takes about 10-15 minutes as an outpatient procedure, we can dramatically lower the pressure, eliminate the major cause of the glaucoma in most cases, and get people either off medication or better controlled on less medication to really bend the curve of blindness.
So is the guidelines changing the strategy from using medications and injections to looking at using the lens surgery instead?
Well, there are new studies coming out now, and that's part of the work that I'm doing. And that's part of the work that I'm doing in my practice to try to show the evidence. We need randomized controlled clinical trials to compare surgery to medications first. We have a couple of studies in the past that show trabeculectomy, which was a gold standard, did better than medications and surgery, but that surgery was a bigger surgery that had about a 30% risk of complications that can occur. But these newer techniques that we have today with cataract surgery and trabecular bypass just recently came out within the last few years, so it's very exciting. So we just need to do more randomized controlled trials to get the evidence to change that standard of care.
Okay, so I wanted to talk to you, like, can people do anything, like, let's say you have a family history. Like, I'm a cardiologist, and when people have a family history, we check their cholesterol and check them for diabetes and control blood pressure and risk factors. But what about, when you talk about eye, is there any sort of eye care that helps prevent the onset of glaucoma? Or if you have a family history, you're definitely going to get it?
Well, if you have a family history, you're at higher risk. There are environmental factors that can contribute to glaucoma. So
that's what I mean.
Yeah, I mean, the best medicine is a healthy diet with lots of salads, lots of vegetables, baked chicken, baked fish, drinking water. So a healthy diet is the best medicine. Exercise is very important to stay physically fit, have a good cardiovascular flow, to maintain improved outflow in the eye. That's very important. Meditation and decreased stress is very important, to be very mindfulness. So sometimes practicing yoga and just, de-stressing yourself at the end of the day helps helps to also, you can lower the eye pressure by about 20%, your blood pressure as well by 20%, just by meditation and mindfulness as well. So those are three important things that we should all be doing for all aspects of our health. But the most important thing thereafter is just getting your eyes checked at least once a year to get your eye pressure checked and get checked for glaucoma as well.
And what about wearing sunglasses when you're outside?
Sunglasses help to protect against cataract formation. That can also help protect against glaucoma from enlarging of the lens too early. The UV light. If you're doing a lot of outdoor work, for those workers that are working outside a lot, definitely protect your eyes from ultraviolet light. Absolutely.
And we have a call from Ron in New Jersey. I'm going to welcome Ron. Ron, welcome to Beyond the Heart.
Oh, thank you, doctors. Yes, I'm 84 years old. I've had myopia since I've been 10 years old, 74. And about 10 years ago, I got glaucoma. And as you know, the doctors, the normal test to check optic nerve damage is the field vision test. And I question the accuracy of that. One of the reasons is I have an enormous amount of floaters. So when I'm taking the test, it kind of sometimes blocks the little tiny light. And I also take the picture of the optic nerve, which to me is more positive in determining optic nerve damage. But what do you have to say about the field vision test, the accuracy of that field vision test to determine optic nerve damage? And what is the latest in technology? I heard some words about stem cells to rejuvenate the optic nerve in a clinical trial. Yeah.
I'll have Dr. Laroche answer that.
Okay.
Daniel?
Okay.
Well, thank you for your question. Yes, when you do go to the doctor, in addition to them examining your eye, they will do some tests on your eye as well. They'll take a picture of the optic nerve to document the appearance and look for glaucomatous damage. They'll do an OCT test, optical coherence tomography, that measures the thickness of the nerve fiber layer, that's the part of the retina that's affected by the glaucoma. And they'll do a visual field test that checks the peripheral vision, your side vision, and your central vision, the central 24 degrees where a lot of the glaucoma damage takes place in the eye. And that is a subjective test because it does depend on how much the patient understands how to take that test, to press the buttons, to respond to the appropriate stimuli. And so, yes, I do have some tests that are fully reliable, but then sometimes there are tests that are not that reliable. And so usually when we make decisions about making a diagnosis of glaucoma or managing glaucoma, we don't rely on one test alone. We do look at the visual field test, we'll look at the OCT test, we'll look at the optic nerve pictures, we'll look at the intraocular pressure, we'll see how the patient's doing, and so we'll make a decision once we look at all these factors put together, not just on one test. So I agree, sometimes if you didn't do that well on one test, or one test you don't think came out that good, you could always repeat it down the line. There are some people that don't do well with visual field tests for whatever reason, and so we'll rely on the OCT or fundus photos and pressure more reliably in that respect. So we don't like to make our decisions just based on one test alone, because we're not treating the test, we're treating the patient, so we want to look at the totality of everything going on.
Okay, thanks for calling in, Ron. We're going to welcome Susie in Miami. Welcome to Beyond the Heart, Susie. Susie?
Yes, hi.
Hi, good morning. How can we help you?
Hi, good morning. I inherited the glaucoma from my father, and so did my sister. But her ophthalmologist told her that there were two types of glaucoma, and one that needed the drops and one that did not need the drops. And in her case, she does not need the drops. In my case, I do. But we have not been able to figure out or understand what the difference is between one and the other. Can you explain that?
There are some glaucomas that are rarer, that are not necessarily pressure-induced, but more decreased blood flow-related glaucoma. People with low blood pressure, hypotension, if they have low blood pressure, that can contribute to their glaucoma, and certain systemic diseases related to that can contribute to glaucoma. And so that would be an instance where you wouldn't want to use a drop to lower the pressure further, but maybe do some modifications to raise the eye pressure if the blood pressure is too low, or raise the blood pressure in itself. I've seen that happen, but that's sort of rare. And like I said, my approach to glaucoma patients, how old may I ask you are? How old are you, ma'am?
I'm 64. My sister's 62.
So my approach to glaucoma in patients over 50, usually I'll find an enlarged lens, narrowing of the angle, and or pigment liberation obstructing the angle. And if they have any of those findings, I would usually recommend earlier cataract surgery or clear lensectomy and opening up of the drain to get people off of eye drops and remove the cause of that glaucoma. That's usually the large lens in that respect. So that's another option as well. I do want to go back to I'm sorry?
Go ahead.
Okay. No, because one of the things that happened with my sister is her pressure was high. And that's why I was concerned if her pressure was high, why she was not being treated for with the drop.
Yeah, the normal pressure is 15 in the eye, assuming a normal corneal thickness, unless her corneas are very thick. If someone has a very thick cornea, you can get an artificially high pressure of 21 or 22 that's not damaging the eye. It's due to the thick cornea. That's the only thing I can think of in that situation. But if she has a normal corneal thickness around 545 microns and you're saying her pressure is very high, then she's probably needs some sort of a treatment for that to lower the pressure. You may want to just get a second opinion as well.
That's a good recommendation. I think it's important if you're not sure to get a second opinion. You know, Daniel?
Yes, and then actually, I
think we both should.
To the previous caller, I forgot to answer his question about stem cells.
Ron? Yes.
He asked about stem cells.
Yes.
There are some studies going on right now to look at stem cells. There's nothing that's been approved as of yet to do that. There is some promising data coming out with regeneration of the optic nerve and animal studies in that respect, but that's very, very preliminary, and you do have to be careful because internationally there are some people abroad that are sort of marketing and advertising stem cells for glaucoma to restore vision and injecting stem cells in the eye, but it's not working. They're sort of just taking advantage of people, charging tens of thousands of dollars for something that doesn't really work. So I know
it has to be sorted out. We have Sherry in we have Sherry in California. Hi, Sherry. Welcome to Beyond the Heart. How can we help you?
Good morning. Thank you so much for taking my call.
My pleasure.
I am 68, and when I was 51 and 52, I had cataract surgery in both eyes successively. And I'm wondering if that earlier cataract surgery will lower the risk factor that the doctor was talking about for glaucoma now later in life, or does that only apply if it's done to make it smaller and relieve the pressure at the time that you have glaucoma?
Interesting question.
Thank you for your question. Absolutely. We have data that shows that with those countries that have access to cataract surgery have much lower incidence of angle closure glaucoma. Okay, from what I'm seeing, patients that I do cataract surgery on, it definitely lowers your risk. It eliminates your risk of developing angle closure glaucoma and dramatically lowers your risk of developing open angle glaucoma because you will now have the lens that's enlarging, narrowing the drainage Schlemm's canal and or rubbing against the iris to release pigment that blocks the trabecular meshwork. I do surgeries every week. Half of my surgical cases are earlier cataract surgery to help prevent glaucoma. We can actually prevent glaucoma in many cases with earlier cataract surgery. For angle closure glaucoma, before I used to do this laser called laser iridotomy to open up the drain. Okay, I don't do that anymore. I do earlier cataract surgery in those patients. If they have a high pressure due to a narrow angle and a large lens, I'll do earlier cataract surgery to help eliminate that cause of the narrow angle and prevent glaucoma as well as much as possible.
Okay, and thank you for calling. We have one last caller, Terry in Maryland. Hi, Terry. How can we help you? Terry? Terry?
Yes, hi.
Hi.
I have a question. Hi. I was just wondering, so you do have glaucoma and you are taking the drops. Is there a better time of day to take them, like first thing in the morning or before you go to bed, if you're one time a day?
Well, The prostaglandins are the most common prescribed medications. The studies were done with dosing them at night, and so we dose them at night to get that same maximum effect. I like to dose the medications, if they're 1 or 2 drops in morning and night. Usually when they're at home, it may be near the bathroom. I tell my patients to keep it near their toothbrush, so if they brush their teeth twice a day, at the same time, get into routine of putting their drops in right in front of the mirror, so they don't forget. I try to, if my patients have to be on eye drops, I try to do either once or twice a day regimen around it to make it easier to simplify compliance.
Okay, and if it's once a day, the study showed it was done at night.
For the prostaglandins in the evening, those are usually the once a day ones, correct?
Okay. Does that answer your question, Terry?
Yes.
Okay, thank you. And Dr. Daniel Laroche, I want to thank you so much for joining us today, and look forward to hearing, having you come on again to share your research with us again.
Thank you so much.
Thank you.
If people want more information, they can visit my website at www.advancedeyecareny.com. And thank you so much. It's been a pleasure.
Thanks. We'll put that out on the Dr. Radio Facebook page as well as tweet it. And I want to thank all of our listeners for joining us today during our live broadcast of Beyond the Heart on Thursday from 10 to noon. And we're going to take our break right now, but stay tuned because the doctor is always in on Dr. Radio.